Good morning, good afternoon, wherever you may be. Thank you so much for being here. I'm Grace Rubenstein, Editorial Communications Director with Health Begins. Thank you so much for coming to our webinar, First Do No Harm, Healthcare Profiteering, Hospital Never Events, and Implications for Racial Equity. Is going to be a really powerful hour. As we get started, I just want to give you a heads up about a few of the ways we're going to run this webinar. It is being recorded. There will be slides shared at the end of the webinar, as well as a recording. All of your lines are going to remain on mute during this hour, but we really care about this being a dialogue. We want to hear your ideas, your resources, and your questions. So we're going to keep a lively chat going throughout the hour, and we are also going to reserve time at the end for a lively Q&A. In fact, let's get the chat started right now. If we can do a little practice, please take a look at the chat window. You can find the icon at the bottom of your screen and make sure it is set to everyone, to send to everyone, and let us know where you're coming from. We'd love to hear the full range of organizations and geographies that folks are joining us from. All right, I will say hello right here, just as a little demonstration. Great. All right, we're crossing the country already. So as we launch into this discussion, just a reminder, please to bring and share respect, curiosity, and joy in today's session. We will all be doing the same. It's my honor to introduce today's panelists. We have Bernita Haynes with the National Consumer Law Center, Quinn Chi Wen with Community Catalyst, and then presenting together, Dave Chokshi and Adam Beckman. Dave from Bellevue Hospital, CUNY School of Public Health and Health Policy, and the former Health Commissioner of New York City. Adam, my slides are being covered here, sorry. Adam from Harvard and formerly from the Office of the U.S. Surgeon General. These folks are such treasures to be with us today, and they're going to really help deepen our understanding of some of the entrenched practices that we have in healthcare that may be doing harm and what to do about that. So our objectives, learning objectives for today, which we're about to dive into, are to identify predatory financial practices and the ways these practices harm patients and drive health and social inequities, to describe racial capitalism, its relationship to healthcare profiteering, harmful financial practices, and medical debt. We're going to unpack the racial capitalism terminology a little bit, and to describe never events and other concrete steps to help leaders identify and end abusive practices and harmful medical debt. That's the next steps springboard for the conversation. So with that introduction, welcome everyone, and it's my honor to introduce our host for today, Rishi Manchanda, CEO of Health Begins. Rishi.
Thank you so much, Grace, and thank you all for joining us today. My special gratitude to our presenters today who you're about to hear from. I thought I'd take a moment just to do some table setting here for our conversation today. I'm Rishi Manchanda, I'm CEO at Health Begins. We can go to the next slide, please. Health Begins, as many of you may know, and for those who don't, just a brief orientation, we're a design implementation firm that helps Medicaid-serving clients move upstream and advance health equity for people and communities who are harmed by societal practices. Our big goal is to really partner with clients, with our partners in the field, directly to be able to transform systems for health equity with 250 communities across the country by 2025. If you click once, you'll see one element that I've alluded to is this idea of moving upstream. When we talk about that, we mean something very specific, and that means really accompanying and supporting courageous leaders across the country. We have the privilege of working with folks in a variety of healthcare settings, hospitals, clinics, health plans, and what we do is have the privilege of working and supporting courageous leaders in all of these settings to move upstream, specifically meaning to address the social, institutional, and the structural drivers of health equity in order to advance better outcomes and equity for all people. The next slide, please. A big part of our work is helping to align with the strategic priorities for a lot of us, both in health and healthcare in particular. The quintuple aim, some of you may be familiar with the triple aim, the quadruple aim, and of course, more recently, especially with equity at the center of a lot of our work, the quintuple aim. As we define the quintuple aim in this kind of way, placing right in the center, there's this question of equity and depicting how it impacts all dimensions of healthcare. One of the important things as we move to the next slide is the recognition that achieving the quintuple aim certainly takes identifying inequities, but it's more than just identifying inequities and working to address them within current systems and structures. It's also about identifying when there are elements within our systems and structures, both in our society, in our communities, and also within our institutions that may be causing harm. And this is an important point before we move on. I want to stress, this is true for all institutions, both in society, across sectors, criminal justice, education, the social sector, as well as the healthcare sector, right? And within the healthcare sector, it means identifying that there are practices that each one of our major stakeholder groups, whether it's pharma, insurers, health plans, crediting organizations, provider groups, hospitals, clinics, every one of us has a duty in many ways to be able to identify when inequities exist, and then to be able to root out those practices where they do exist, and including practices that may exist within our own systems. Let's move to the next slide. This is especially important given the fact that many healthcare systems, rightly so, are putting words out, putting out commitments, in many cases very authentic commitments, to be able to advance racial justice, to be anti-racist. And what we, of course, understand is there's a lot of work involved in being anti-racist as an institution. At the basic level, it means getting grounded in an understanding of what structural racism is, what institutionalized racism is. Of course, it also means identifying using data, stratification, collection, all the technologies that we have at our disposal to identify inequities, especially racial inequities. But then it also means asking, as Dr. Ibram Kendi from who wrote How to Be an Anti-Racist as I described, it also means then asking what's wrong with policies, what's wrong with conditions, what's wrong with systems and structures, rather than saying what's wrong with the people. And then, of course, working to right those wrongs. So looking at structures and systems is a key part of what it also means to be an anti-racist institution and an anti-racist leader. If we go to the next slide, the bottom line as we tee up today's conversation, I think, especially in the framing for our dialogue today, is that we understand in our work, as many of you do, that equity really is a process and an outcome, right? It's a process that serves as both a magnifying glass and as a mirror. It helps us see otherwise hidden harms, and it also helps to reveal the practices, the systems, and the structures that cause harm, whether those practices, systems, and structures are in our society or within our own institutions in our communities. So with that in mind, as we look at the next slide here and think about the conversation for today, as I get ready to present, let me ask this question. This is not going to be a formal poll. We'll use the chat instead, using A, B, C, D, or E. Let's just quickly get everybody's sense. How concerned are you about harmful financial practices in healthcare, obviously the topic of today, and how they impact health equity? A, not at all. B, not much. It's an issue, but it's not a major one. C, somewhat. D, very much. Or E, you're not sure. And any answer is fine. Great. Not surprisingly, obviously, we have a selection bias going on because you showed up to this conversation. We're not surprised that many of you think D. We agree. We think it's an important topic. It's not the only driver of inequities, of course, but it is an important one for us to come together and at least identify, applying both that magnifying glass as well as that mirror. So as we go to the next slide here, what we'll hear about today is a bit more about harmful financial practices, where they exist, what they are, and the ways in which they are undermining health equity and commitments to racial justice. An important point here is this, as the American College of Physicians themselves have identified, the pursuit of profit is not inherently negative unless it compromises the patient-physician relationship, worsens health outcomes, or exacerbates health disparities. And as we take that in mind today, I think we'll see, of course, therefore, certain financial practices are concerning, given their impact on the relationship on health outcomes and inequities. particularly when we look at the evidence that more than 100 million US residents are experiencing debt because of medical issues, with a disproportionate impact falling on historically marginalized communities, Black, Latino, and other racial and minoritized communities especially. And this is also important because for many of us who are doing a lot of work moving upstream, addressing social risk factors, it's also important because we realize that medical debt, for example, is itself associated with a higher risk, a significantly higher risk of worsening social determinants or social needs, including housing and food security, as research has demonstrated. So with all this in mind here, with the table hopefully a little bit better set, let's now move to the main conversation today. And it's my extreme privilege to go to the next slide here to introduce our first set of presenters who are going to walk through these questions. Bernita Haynes from the National Consumer Law Center. Bernita, welcome so much. A lot of your work has been really, really helpful for us at Health Begins as we think about how to engage in conversations with a lot of the stakeholders we work with, the courageous leaders in healthcare who are trying to move upstream. And so thank you so much. I'll turn it to you.
And thank you so much for having me here to talk about an issue that just keeps on giving. Hi, I'm Bernita Haynes. I am going to talk a little bit about the racial health and wealth gap, addressing medical debt as a racial justice issue. So you can advance to the next slide. And very quickly, a little bit about NCLC, my firm, my organization. We've been around since 1969, working hard for consumer justice and economic security, specifically focusing on low-income folks and older adults. Providing expertise in policy, advocacy, publications for practicing attorneys and legal aid and so forth, litigation, serving as expert witnesses, and training. You can find more information about us at nclc.org. Next slide. And a very, very quick background on me. As I said, I am a staff attorney at National Consumer Law Center. I focus on consumer energy policy, randomly, and medical debt, and recently authored NCLC's The Racial Health and Wealth Gap, Impact of Medical Debt on Black Families. Before joining NCLC, I served as a director at Georgia Watch, a consumer watchdog organization here in Atlanta, where I am still based, where I wrote the Georgia Consumer Guide for Medical Bills and Debt. Next slide. So let's jump right into this. What is the racial health and wealth gap? Very generally, the racial health gap refers to disparities in healthcare and access, healthcare quality, and also health outcomes of households across race. The racial wealth gap refers to disparities in income, assets, that includes homes, savings, investments, and debts of households across race. So what does the racial health gap actually look like? Chronic conditions and health risks like cancer, infant and maternal mortality, heart disease, etc., disparately impacts Black families, and Black individuals have higher uninsured rates on top of that. In fact, in Georgia, I believe we have the third highest uninsured rate in the country. So what does the racial wealth gap look like? In 2020, the Federal Reserve reported that the median net worth, that's all the assets an individual owns minus their outstanding debts, of Black families was $24,000 compared to $188,000 for white families. So a very alarming gap that has a long-standing history, right? Gaps in wealth and health intersect to worsen the medical debt crisis for Black families. Chronic conditions and being uninsured leads to more medical bills. Pretty common sense. Poor health or chronic health problems and lack of insurance are actually the biggest risk factors for incurring medical debt. People with chronic conditions regularly report that they have more medical debt as a result of that. Lack of wealth means medical bills are more likely to present a financial hardship for Black families than for white families. So families with more wealth can weather the storm of that $1,000 or $500 medical bill, whereas folks with less wealth can't. This can actually contribute to a very vicious cycle where individuals avoid necessary health care because they're worried about the cost, and therefore experience greater health problems that can lead to more medical bills down the road. Overall, Black households carry medical debt disproportionately compared to other groups. 1 in 3 Black adults have past due medical bills compared to fewer than 1 in 4 white adults. 17% of Black adults lack health insurance compared to 12% of white adults. Notably, households in the South, the region with the highest concentration of Black folks, carry more medical debt than households in the Midwest, West, and Northeast. Longstanding systemic racism underlies these disparities in medical debt and health outcomes. Next slide. So what does all this even mean? Well, in a nutshell, systemic racism, number one, influences who has medical debt. Number two, existing policies, specifically charity care or financial assistance, that should address the problem, provide an insufficient safety net and insufficient protection for families that need it the most. Additionally, debt collection disparately impacts Black families and is particularly aggressive. And finally, federal solutions are desperately needed. There have been a lot of great state solutions, but federal solutions are desperately needed. A very brief discussion of charity care and its problems. The Affordable Care Act requires nonprofit hospitals to provide financial assistance to low-income patients, of course. But charity care fails in practice because patients are not informed of their eligibility for charity care before the hospital starts debt collection. The ACA also provides no specific guidelines and minimum eligibility criteria in its financial assistance requirements. And then there's just an overall lack of effective implementation, enforcement, and oversight of charity care in general. This failure of charity care really harms Black folks the most because, as I've noted, Black folks are most likely to be uninsured, and because Black folks are more concentrated in Medicaid non-expansion states, i.e. the South, where hospital charity care is more desperately needed, and yet the charity care eligibility requirements tend to be more restrictive. Quickly regarding debt collection, as alluded to here, debt collectors contact Black households at twice the rate of white households. You can find some information about this at the FTC. Aggressive debt collection practices result in undue stress, loss of income and wages, liens on homes, and other long-term harm to financial stability and health. Medical debt and these aggressive practices lead patients to use other types of risky financial instruments like payday loans, title loans, and other risky items to pay down medical debts, trapping people in a cycle of debt ultimately. Next slide. So as noted, federal policy solutions are crucial here in this particular space, and we've seen some movement as of late. The No Surprises Act, which passed in 2020 and went into effect this year, would prevent and prohibit surprise or balanced medical bills in emergency context, including air ambulances, and also in many non-emergency contexts. Blue Cross Blue Shield Association and AHIP have already released new data showing that in the first 9 months of 2022, the No Surprises Act prevented 9 million surprise medical bills from hitting American families, really underscoring the benefit of that particular law. But it has also faced challenges lately from physicians as well as insurers who are concerned about the arbitration portion of that law. The COVID-19 Medical Debt Relief Act of 2021 was introduced but not passed, would have prevented healthcare providers from taking extraordinary collection actions, wage garnishment, that kind of thing. The Medical Debt Relief Act of 2021, 2 companion bills that were introduced but not passed, would have protected consumers' credit reports by preventing credit bureaus from adding fully paid or settled medical debt and medical debt less than a year old to credit reports. Now, as you all may know, credit bureaus have already decided to voluntarily take some of those steps, but we need codification of these protections. So these federal policy efforts that we've seen are very important first steps in tackling the medical debt crisis, but more robust solutions are needed. More importantly, lawmakers really should prioritize relief for Black families because of the severe and disproportionate impact of medical debt on Black folks. Among other things, this really does require focusing on the states where Black people are heavily concentrated and focusing on ways to prevent medical debt at the outset and not after the fact. A range of solutions would go a long way to help resolve the crisis, including improving charity care or financial assistance requirements, such as requiring screening for charity care upfront, broadening charity care to cover uninsured and underinsured patients, and so many other things that could improve charity care, allowing patients to actually enforce charity care laws in court to hold violating hospitals responsible, for instance. But there's so many different ways to improve charity care that we really need to be talking about. Expanding Medicaid in holdout states, creating some sort of program that would make Medicaid-like programs available for folks who would otherwise qualify for Medicaid in the states that have refused to expand. Incorporating medical debt cancellation and Medicaid expansion into a strategy for reparations. Canceling medical debt outright, which has gotten really popular over recent years and is a very crucial part of the solution. And I would be absolutely remiss without saying we need to enact a universal, publicly funded national single payer health plan administered at the state and local levels. Next slide. There is so much I could say, and as you can tell, I could talk about this all day, but suffice to say, please do see my report, The Racial Health and Wealth Gap, for further detailed discussion of these issues and also some of the potential policy solutions. Please do take a look as well at our reports on hospital financial assistance, which was updated recently, and our report on how medical debt affects credit histories and credit reports. Thank you so much for your time, and I will stop there and turn it back over to Rishi.
Pranita, thank you so much for that. And it's a wonderful kind of tee up now to our next presenter, Quincy Nguyen from Community Catalyst. Quincy, thank you so much, and the floor is yours.
Thank you, Rishi. Thank you for including me. Next slide, please. Our healthcare system is quickly changing, and people with the most at stake, individuals and their families, often have no say in the process. So this is especially true for people who are frequently left out or harmed by policy and practice decisions, including people of color, people with disabilities, people with health conditions, LGBTQ people, immigrants, older adults, and women. And when decisions about our health system are driven by profit, patients and their family often suffer. This is why at Community Catalyst, we work in collaboration with partners around the country, advocating for a health system that is equitable and responsive to all of our needs. We apply a race, equity, and health justice lens by centering equity, harnessing, and making progress on both ideas and building power and unity. Next slide, please. So under our project, the Community Benefit and Economic Stability Project, we work to ensure that community members and partners have a strong voice and receive the support they need to participate in the hospital effort to identify and address community health needs. Currently, we work with community and state health advocacy organizations in 7 states, and you can see the state there, to build community knowledge and capacity, so they can partner effectively with hospital, public health leaders, and other allies. Next slide, please. Last year, we collaborated with our partners to develop a set of 5 equity principles using the IRS 501R regulation as a leverage to promote policy that better serve communities and do no financial harm. So the focus of these 5 principles is 1, to advance patient-friendly financial strengthening policy at the hospital, local or state level. Number 2, to improve hospital building and collection practices to eliminate medical debt for low and middle income families. And number 3, to identify opportunities to collaborate with leading community hospitals to identify the next generation of community benefit. Next slide, please. So the 5 principles are equity, transparency, affordability, inclusivity, and accountability. So let me go quickly over each of these 5 principles. So on the equity principle, it is always expected that hospitals stay true to their mission of providing services and care to the community they serve. So to ensure hospital policy do not discriminate against people based on demographic factors such as age, gender identity, race, disability, health status, language, immigration status, hospitals should examine processes and data on who receive financial assistance, as well as those who are subject to aggressive collection action. And data should be stratified and analyzed to examine whether they are disparate experiences. So the second principle is transparency. So we heard from our partners that many people don't know about the availability of hospital financial assistance programs. So to ensure that patients clearly understand their rights and have access to the support they need, either when applying for financial assistance or when they have questions about their medical bill, hospitals should, at the minimum, inform patients that they can apply for financial assistance. And also, given that a patient's financial circumstances may change over time, hospitals should offer to screen patients so they can have ongoing opportunities to apply for financial assistance regardless of where they are in the billing cycle, even after their bills have been transferred to a collection agency. The next principle is affordability. So I think this is very straightforward. Hospitals should never employ or should prohibit third-party agency acting on their behalf from employing collection practices that impoverish patients and worsen economic inequality. So the practices include, for example, taking legal action such as freezing a bank account, garnishing wages, or placing liens on property vehicles. So the next principle is inclusivity. As important anchor of community they serve, hospitals should be responsive to community needs. And so to ensure to respond to the changing demographic and financial status. And so hospitals should work and invite feedback from patients who have received financial assistance, for example. Also, like in order to collecting feedback, hospitals should partner with community-based organizations or community health workers, because these entities are the trusted organizations in the communities. And the last principle is accountability. So I could emphasize that the importance of the educating staff, both inside and outside of the billing department, on financial assistance policies, and be transparent that this program exists. And we also think that it is beneficial to conduct annual review on all financial assistance billing and collection policies to make changes to address involving community needs based on inclusive feedback practices. Because we believe that annual review could help prevent the never events that our next two speakers will discuss in a few minutes. So I turn it back to Rishi.
Quincy, thank you so much, and really want to encourage and stay on this for a moment here. We'll put the links to Community Catalyst as well in the chat here, including the contact information that you shared, Quincy. Thank you so much for that. And as you were just doing at the tail end of your comments there, this is a good segue then to our last set of presenters here. If we go to the next slide, Dave Chokshi from New York, former health commissioner in New York City. Dave, thank you for joining, and Adam Beckman as well. It's my pleasure to welcome you both to take the floor.
Thank you so much, Rishi. And I want to also do a special thanks to Health Begins for convening this really important conversation. My wonderful colleague, Adam, and I feel very grateful to be a small part of it. You can advance the slide. And look, I want to start by saying and acknowledging that when we talk about things like the vicious cycle of poverty leading to illness, leading to more poverty, or the racial wealth gap, or the staggering medical debt that is burdening so many families across our country, it can feel very paralyzing. Certainly it has for me to think about what it is that that we should do for our patients, for our communities amidst what are these complicated Byzantine, entrenched problems. And that's really the spirit with which Adam and I, started to think about what we'll describe as hospital never events. It derives inspiration from the idea of medical never events. It's actually the 20th anniversary of those clinical never events, which were first identified by the National Quality Forum. You've heard of these before. It's things like operating on the wrong limb of a patient. It's things that indicate a severe problem with the quality or the safety of care. And the idea of those never events galvanized a movement in the healthcare system in the 2000s and beyond that really boils down to the notion that some outcomes are simply unacceptable. So, if you look at this X-ray, I know many folks are not clinicians in the room. So if you advance the slide, it points out, one of these never events, leaving sponges inside of patients during surgery. And this was something that it was straightforward for us, as a community, a healthcare community, to say, this should simply never happen. This is unacceptable. Even though to that point, the idea that some of these events were, and these harms were inevitably a cost of doing business in hospitals was something that hadn't been challenged on the same grounds. You can advance the slide one more, please, Grace. And so, fast forward 20 years, and our, what we would like to posit is that the never events that we should be talking about right now are around another set of behaviors that ultimately harm patients, but they're primarily administrative rather than clinical. So the example that's given here is the New York Times story that some of you may have seen, specifically around aggressive collection of medical bills from patients who can't afford them by the Providence health system, which, according to this report in the New York Times, hired debt collectors to pursue money from low-income patients who should qualify for free care. But beyond, those individual hospital practices, there are systemic considerations. For example, an estimated 72% of private nonprofit hospitals had what's called a fair share deficit, meaning that they spent less on community benefit than the estimated value of their tax exemption status. So we're going to talk a little bit more about these specific never events. And for that, I'm really pleased to pass the baton to my colleague, Adam Beckman.
Great. And thank you, Dave. And just echoing Dave's comments, thank you, Rishi, and the whole Health Begins team for bringing us all together. We can go to the next slide, Grace. So as Dave alluded to, we then wrote a short piece several weeks ago in JAMA Health Forum called A New Category of Never Events. And we write about this idea that certain hospital practices that are occurring today should become unacceptable because they're harming patients. And I think this list complements what you just heard from our colleagues from Bermuda and from Quincy. You can advance the slide. And we specifically suggest 5 practices that should be considered hospital never events. Next slide. The first is that hospitals should never pursue aggressive debt collection tactics against low-income patients. So this includes suing them, garnishing wages, denying care due to owed debt. Second, we discussed that a hospital should never spend less on community benefit than a hospital earns in nonprofit tax breaks, getting to that fair share deficit that Dave just mentioned. And third, we read that hospitals should never flout federal requirements to be transparent about costs of care. And fourth, we discussed that hospitals should never provide compensation worth less than a living wage for hospital workers. Finally, a hospital should never deliver racially segregated medical care, whereby a hospital surrounding communities of color. And certainly we recognize that this list is just a starting point. Already we've heard from folks with additional ideas, for what should be included in a hospital never events list that's even more fleshed out. And we welcome you adding some of those to the chat as well. And the data on the right side of the slide here starts to give a sense of the scope of these practices. For the sake of time, I won't go through all of them, but we're happy to share some of that evidence as well. So since so many of you work with hospitals, we'd like to open up the conversation with a poll for a moment. If you work at a hospital or with a hospital, how many of these never events do you think that hospital engages in? And we'll take a moment to let you respond to the Zoom poll that Grace kindly just put up here.
Adam, I'm going to give this just an extra moment because I think folks are digesting the text.
Fabulous.
We'll give it another 20 seconds or so. All right. 5 more seconds. Still coming in. All right, you should be able to see the results on the screen there. It's pretty distributed across all 5, to be honest. But you see number 2 and number 4, to some extent, number 1 is particularly high.
Great, and thank you, Grace. And agree. And I think what's striking is for most of these, you all are reporting that the majority of folks are reporting that the hospital they are thinking of is engaged in that never event. And so I think that just speaks to how widespread these challenges are and how much work there is to do here. So let's go on to the next slide. And before we go further in terms of thinking about policy solutions, I think it's worth just pausing to ask the question that we asked ourselves of why focus on hospitals. We can advance this slide. Of course, having this conversation isn't to ignore the ways that hospitals massively benefit us all. During the most intense parts of the COVID pandemic, for example, we've seen that the people who work in hospitals, administrators and clinicians have again and again demonstrated an exceptional capability to serve people. And we can advance this slide. We believe that other healthcare organizations, whether it's insurance companies, medical device makers, undoubtedly there are other harms that are happening across the healthcare ecosystem that deserve dialogue. Next slide. But the fact that the majority of hospitals are engaged in one or more of these 5 never events, including based on the poll data that we're seeing here, means that we believe patients would benefit from that cycle being interrupted. Next slide. And we see that this work, the hospital never events framework, can actually, rather than adding another burden, help to clarify that a hospital's first responsibility should be to stop creating social harms. Next slide. And I know that we're starting to get tight on time here, and we want to make sure we get to the Q&A. So I'll just very briefly speak to what the future might hold. Next slide. Across the country, momentum is already building. We talked a bit about the Loan Institute rankings that rank hospitals in part on social responsibility and some of these metrics. Certainly, there are a number of organizations that are working to reduce hospital never events, like the ones around medical debt, including many of your organizations. And there's been terrific reporting recently, both nationally and in local regional outlets on these challenges. Next slide. And so before closing, I would say two things. One is that hospitals themselves can lead the way here. That was very much the case in the clinical never events movement. And we believe that there's an opportunity here for visionary hospital leaders to really step forward. And a number already have. And in that same vein, frontline workers have been speaking up, and there are hospital systems that the data already shows are doing exceptionally well. Next slide. But on top of that, these practices also probably require policy action. And so we can delve into this more in the Q&A, but we see opportunities at the state level, both in the legislative side, on the enforcement side, and certainly federal regulators have a role, as you heard from our colleagues previously. So I'll pause there. Thank you all for being here, and we're really looking forward to continuing the conversation.
Adam, Dave, thank you both so much. Let's jump right in then to this kind of dialogue, especially given how robust the chat is right now. And we've been, with my colleague Grace's help, curating some of the questions that have been coming in as well. So let's now engage. Bernita, Quincy, Dave, and Adam. Thank you so much for the presentations. As you can tell, there's a lot of engagement here. Let's move to the next slide here. And a couple things that I'll reflect on, just to reflect back, I think some of the things that we've certainly learned from each of you and other incredible organizations in this space, as we think about how to then make it actionable, how to take what is clearly unacceptable in the way that you've all described, especially where you landed, Dave and Adam, and now take action to take those things that are unacceptable and move on them, building on what Dave and Adam talked about and what Bernita and Quincy talked about. There are 4 R's that we can put out in the newsletter not so long ago at Health Begins, 4 ways to help end some of the harmful practices when those practices are identified as contributing to harm for your patients or your communities. One is the review process, just to see if this is actually happening. There are various resources that we've identified here, including the framings that have been shared today. The second is to reform, right? To then engage in supporting changes to your own hospital's financial practices, whether you're working inside a hospital, you're a patient who attends certain hospitals, or you're an advocate in the community trying to support your hospitals to do better. And there's a variety of principles, including the ones specifically that Quincy mentioned, that are there as well, and actions that can be taken to end those practices that are harmful. The next slide, besides review and reform, is this idea of redress. I'd love to get feedback both online from everybody in the room as well as our presenters today. This idea of how to then provide redress for when a harm is identified, much like we provide redress for other situations in harm. When it's documented, how does one, especially somebody who's committed, who's mission-driven, committed to advancing health equity, how do you actually take part in helping to restore and build trust in a situation where harm has happened? And how do you then make sure that it doesn't recur, all right, and through both individual changes at the institutional level to practices. And lastly, then this idea of reimagining, advocating for the policy changes that can take what is clearly have been defined as unacceptable, harmful kind of practices, and then changing those policies at a state and federal level in the ways that you guys have all described. So this idea of these kind of the 4 R's, the review, the reform, the redress, and the reimagine, are things that we had put forward as a way to at least start the dialogue here that we're continuing today. As we go to the next slide here for turning it to our colleagues. This is 3 questions. We don't have to go through them in order right now. This is really now unmuting our friends, all of our presenters today. I want to put these out there and maybe start with number 2 first, and then I'll bring in a question from the audience. I think all of you have done a wonderful job of describing some of the harmful financial practices, which we addressed in question 1 on the screen. But I also want to get to some of the real resistance that people can encounter when they try to end these practices as well, both working within and outside of institutions. I'm curious what kind of resistance you anticipate or you've seen advocates or courageous leaders experience, and what tips you have. Question number 3 for those who are trying to overcome that resistance. It's a jump ball question, so I'll invite the first person in to start us off. What's the resistance that you think might be experienced by those who are trying to embark on these conversations internally? Why don't we go in reverse order? Dave and Adam, and then we'll go to Quincy and Bernita.
Sure, I'm happy to at least get the conversation started. And one thing to acknowledge is that, when you talk about these issues, you often run into the phrase and counter argument, no margin, no mission. And it's an important one to grapple with because although there is some truth to it, I think some of the ways that you opened up in terms of framing our conversation, Rishi, are important to harken back to. That the argument is not that all sources of revenue are bad, or even that all sources of profit are necessarily evil, but rather that there are these harmful practices even within sort of the lawful and legal architecture that we have, whereby we can protect patients and protect our communities better. So that's certainly internally in conversations in hospital systems that I've been privy to, a big piece that one has to anticipate. And I guess the piece that I would offer by way of counsel in terms of surmounting it is to not sort of fall prey to the trap of trying to directly counter it, but actually to acknowledge it and say, but are we pitting two things against each other that are actually a false dichotomy? And to use that to say, look, we are on the same team. We know that investments mean that we can serve our patients better, but we also need to be very realistic about ways in which our practices may be harming patients today that can also be redressed.
Really appreciate that, Dave. Yeah, and Adam, Quincy, and Bernita, especially to pick up on that, and maybe even go into the harmful financial practices themselves and this concept of racial capitalism that some have not used necessarily as a frame to come at this issue is an important one that can also be really helpful to kind of ground the conversation so it doesn't end up being caught in these kind of traps of false dichotomies, as Dave was talking about. So I want to open the floor to you in terms of any comments in response to what I just teed up or anything else you want to raise.
Yeah, I'll jump in. Oh, I'll jump in real quick. And I'll just say that in terms of this first question about why does this matter for organizations that are committed to anti-racism? I didn't go into it in depth in my discussion, but the medical debt crisis is one that is completely inflected by a legacy of systemic racism. And we see that in every facet of how medical debt actually materializes. The states that didn't expand Medicaid, for instance, are exactly the states where we saw a very Jim Crow type of healthcare system. The southern states. That's not to say that we didn't see a Jim Crow type of health system in the northern states, but it looked different up north. It wasn't that Black folks lacked access to any healthcare up north. It's just that they had access to inferior healthcare facilities. In the South, however, we saw a complete lack of access to any healthcare facilities during the Jim Crow era. And all of those kinds of legacies, they don't stop. There's a sort of unbroken chain from the past that is very much reflected in today's issues around access to healthcare. The chronic conditions that Black folks are disparately impacted by, all of that is part of what it is like to be a Black person in this country and deal with racism day in and day out. The stress it causes, people not believing your pain when you go to the doctor's office, and all of these kinds of things. So I think it is extremely important that any organizations committed to anti-racism recognize that we cannot talk about the medical debt crisis without talking about racism, and we certainly can't solve it without targeting how structural racism materializes in our healthcare system.
Quincy, thank you, Bernita, for that. And Quincy, I know you also wanted to chime in.
Yeah, thanks, Rishi. And I second what Bernita said about the importance of addressing structural racism in our healthcare system. And another thing I want to emphasize that that there's a power dynamic, unequal power dynamic between communities and hospitals. And oftentimes community members are excluded from the decision making that affect their health. So in order to really address the health needs in the communities, we really need, and community catalysts really encourage a hospital work with community leaders to really go work together, go to the table together, and discuss what exactly is the needs that in the communities, and just invite feedback from communities, because without their feedback, without listening to their story, you can never create policy that really reflect the needs in the community. So I would say that allow community members to come to the table, set their own agenda, set their own policy, and work together to address and implement these policies.
Yeah, I think just incredible, amen to that point, and I think it resonates a lot with what we've seen from a lot of courageous leaders who are now engaging in conversations in both how to identify and address inequities through reforms in clinical practices, and increasingly how they're also engaging in conversations along with administrators, vanguard, courageous kind of administrators, to be able to identify administrator practices that can also change. There's two questions I want to kind of surface that kind of build on what you all mentioned. One is a question that came in from Rachel, I think it's Steinbeck. Rachel, forgive me if I'm mispronouncing your last name, but one of the questions that came in from Rachel is, what have been the most successful efforts thus far to improve charity care or ensure people who are entitled to it actually receive it? And there's another question that's kind of related I'm going to put in here. It's coming from Barbara Sattler regarding kind of potential resistance. Hospitals may ask, how are they to cover their costs if not collecting these debts? So, successful efforts to improve charity care and make sure those who are entitled to it receive it. And also this question about, well, what about that potential resistance? Well, especially in an environment where there's been a lot of financial pressure during the pandemic on a lot of hospitals, what if they say, well, how are we going to cover our costs if we don't collect these debts?
And Rishi, perhaps I could jump in just on that second point, which I think is a really important one, and one that Dave and I have certainly talked about at length and with colleagues. And I think, the first piece is that these challenges are real. And with that, if anything, our fear about the ways in which financial pressures could actually worsen some of these never events has grown. And we think part of the reason why it's so important to be talking about these never events now is so that they are not sort of doubled down upon in order to address those challenges. And I think the second part of this is that in many cases, engaging in these never events are not real solutions to those financial pressures that hospitals are facing. And there are many other policy and sort of strategic solutions that should be discussed and on the table. And at the risk of sort of getting too in the weeds here, one of the articles that was shared in the chat that talks about a hospital system, has some data in it discussing sort of the small share that sometimes these lawsuits are for, the small amounts of dollars that these are representing for the hospital in terms of revenue, but the massive burden that small amount can place on a small number of patients. So, I think what I would say in short is that we agree those challenges related to financial pressures are important and need discussion, but it's not necessarily the case that resolving those means doubling down on these never events.
I will jump in and second Adam on that 100%, how the amounts that hospitals are often seeking to collect are minuscule compared to how actually important and significant it is to the people they're trying to collect from. There have been some interesting reports from Maryland, for instance, from National Nurses United, about how much Maryland hospitals have tried to collect compared to their total net income and revenue. I believe between 2009 and 2018, Maryland nonprofit hospital revenue and net income was around $146 billion and $5.68 billion respectively. And their charity care that they provided dropped during that same period by 26%, by 36% or so, by 100 and something million. The spending on charity care is already quite low. And could use quite an increase. And so one way to deal with, the patients who are not able to pay their bills is to actually use charity care and write those off as community benefits instead of actually billing and hounding the patients. There are a lot of hospitals that actually will eventually write off these debts as bad debts. And that's not terrible, but it's not ideal because at that point, the patients have already been hounded and they've already had their credit ruined. So charity care really is an important way to deal with the issue around, patients not paying their bills and the kind of money that may come out of hospitals' pockets related to that. So I'll just stop there, but I think it's extremely important to just reiterate what Adam said around this is a minuscule amount of money for the hospitals, but a huge amount of money for the patients they're trying to collect it from. And that needs to be kept in mind here.
We have a couple more minutes, actually, maybe in the last 2 minutes here before we get ready to close out this conversation, which is obviously a rich one that needs to be continued, hopefully, in all of our respective kind of communities and institutions. Let me elevate one question. It's coming from the chat as well, from Soraya Asar. A question, and Soraya, I'm just going to read this out. You said, I've been told that as of January 2023, that medical debt below $500 will no longer appear on someone's credit report. Has there been an uptick to send people to collections before this date, or has there been a change in the way organizations are billing because of that? So first, if you could, either Benita or Quincy in particular, if if you can shed light on the impact on credit reports, especially in light of the federal efforts. And then secondly, do you feel like there's any impact on behavior in debt collection?
Happy to quickly jump in. I cannot answer the question of whether or not we've seen an uptick in collections over that amount and whatnot before that went into effect. I will say that it is extremely important how many people that will protect. That said, Urban Institute has data showing the disparities in how much debt white families hold versus non-white families, and it's around $797, the average debt medical debt owed by non-white families. So while that $500 threshold is going to be helpful to a lot of people will still fall outside of its protections. But we are, closely paying attention to that so that if any data surfaces about how many people have already been helped, we're definitely going to be interested in that at NCLC.
Well, let's do a last lightning round right now for comments here. Dave, Adam, Quincy, Bernita.
I just wanted, thank you, Rishi. I just wanted to add two small points that it sort of dovetails with some of the prior comments. The first is to make sure if people aren't aware, in New York recently, the governor did sign into law a bill that prohibited some of the most aggressive practices related to debt collection, particularly placing liens on homes and garnishing wages. So for folks who are in other states, that may be something to look at with respect to legislative action that can be undertaken. And of course, we'll be monitoring that very closely to understand how it changes things in practice on the ground. And then the second piece is to underline a point that Bernita made in her presentation about the importance of existing financial assistance policies and really changing the sequencing of when those financial assistance policies are used for individual patients' cases. Too often it's happening late in the process, once a bill has already been delivered, once a patient is already in debt, and instead, the processes by which someone is determined to be eligible for that financial assistance should be antecedent to when the bill is sent and the patient is put into debt. And this gets a little bit wonky, I know, but there are specific practices known as presumptive eligibility that we've looked into, and probably Bernita can speak to far more eloquently than I can, but which are important to start to set as the default with respect to how this is happening in practice in hospitals.
I know we're at time here. Adam, Quincy, Bernita, any 10 seconds each, if you don't mind.
Thank you, everybody, for this opportunity to speak to you all. Please do check out nclc.org and look at some of our resources around medical debt issues. And feel free to reach out if you have any questions or follow-up thoughts.
I'll just add, thank you again for having us. And we would love to be in touch with folks. We know a lot of you are doing work along the lines of what we've been talking about today. So I'm sure you know how to get in touch with Health Begins and Rishi, and we'd love to hear about what you're doing.
And for me, thank you, Health Begins, to include me in on the conversation. And also, I want to flag that Community Catalyst is hosting a webinar on the Lao Institute Hospital Index on Thursday, this Thursday. So please, there's a link on the chat. So please join if you want to learn more about the hospital index.
Thank you, Quincy, and thank you all. Thank you all for joining. The next slide here will show you some of the next steps here, including the request to make sure you complete a follow-up survey we'll send out as soon as this ends, and also to stay engaged and share your favorite moments from today as part of that survey. This is about identifying and ending aggressive, harmful practices that clearly are not just inequitable, but are also ineffective. It doesn't make sense to send a bill to a patient and try to collect after them when they otherwise are eligible for charity care, and that can be counted towards community benefit. There's a lot of ways in which I think common sense solutions here can avoid a lot of unnecessary harm, especially in the ways that it disproportionately impacts Black and other racially minoritized communities. Thank you all for joining. This is the start of a conversation, and we know this is a part of a long-standing conversation about how to support you all to be courageous leaders as you move upstream and advance health equity. Thanks, everybody. We'll talk to you soon.